It's actually, there's kind of a two-part question. They're related.
Okay.
And this comes from one of our online participants. So Rex Fujiwara asked, first off, how do you respond to patients or clients who want more pressure? And how do you explain this kind of stuff to those who respond well to it hurts good types of manual therapy?
Okay. If somebody wants more pressure, I will try to not have to work any harder than I have to, okay? But if they want more pressure, I'll give them more pressure if that's what they want. Depending on the patient, depending on the context, depending on the problem. I mean, the whole thing, it's all about them, right? It is all about them. But I'm certainly not going to reinforce their belief system that they think they need pressure in order to get better, or that, like, I'm trying to teach people how not to need people like me. If they want a lot of pressure, they should just go lay down on that side. Their body weight is going to give them pressure.
So, one quick question I have for the audience. This is for context. How many people here are familiar with the type of hands-on work that Diane teaches?
Oh, everybody already knows all this stuff.
Just about everybody. So you've seen it, done it, felt it? Okay. All right. Just wanted to make sure.
Okay, what was the second part of the question?
Well, the second part is, if somebody typically responds well to it hurts good approaches to manual therapy, how do you explain this kind of stuff to them?
Oh, you mean how do I convince them to try it? Well, I say, okay, well, here's the kind I do, and it's lighter probably than what you've been accustomed to. And so, you have an option here. You either can try it my way, or you can go to the other person that you used to get your treatment from that you liked.
Okay. So do we have some questions from the audience here? Right down here on the end. So can we get a microphone over there? All right. And anybody else is thinking about asking a question, get your hands up now so you get mine.
No questions.
I know we've got one.
Hi, Stephanie. Thinking about yes-ception and CRPS. Have you had clients with CRPS?
I have.
And do you use manual therapy on the ipsilateral side?
On the what?
On the same side.
On the same side.
Yeah.
Yeah, I do. Yeah, I have and I do. And that might seem daunting or, like daring or something like that. I just go 10 times lighter and 10 times slower. But I want their brain to feel me there and know that it's not a threat to feel something there.
So we've got another question coming up from Simon here in a moment.
Okay.
I just want to know who else is going to have a question. Okay, so we've got number 2. Can we go before you? Okay. I don't think he's asked a question yet.
Hi, Dan.
Hi.
I just have a question kind of related to the pain question, like it hurts good question before. Kind of by definition, we talk about pain as being an unpleasant experience.
Unpleasant sensory and emotional experience of actual or potential tissue damage.
So if oftentimes when you're working with someone, you're not putting a ton of pressure on them, but you're creating that traction through the skin, and they'll give you that input that hurts, but it feels good. So innately, that's not pain. I'm guessing because the only words that they have to use for it is hurt, but they're saying it feels good,
No,
so
no.
it's not
No,
a
you have
painful
to
experience.
you have to be a therapist in that situation. I would say, okay, if it hurts at all, that's not good. Sorry, I'm not going to, like, I would say sorry to the patient, but I'm not going to hurt you just because you think it feels good, because maybe that's just, maybe that's just something that they believe and they don't, like, I want to know what their critter brain's opinion is about that. Well, if I don't feel the critter brain liking it, I'm not going to do it. Right. And critter brains don't like it, really, usually. So.
Okay, we've got a gentleman here in a dark T-shirt, short hair.
Raise your hand. I'm sorry.
In the second row. Ed had a question. Yep, right there. On your right. No question now? Oh, all right.
Hi, Diane. Thank you
Hi.
for the talk.
Hi, Brian.
You speak about drainage of peripheral nerves, specifically at the cutaneous level. If there was someone presenting and was not able to handle touch, like say someone with CRPS in the extreme, would applying this technique maybe at a remote region of the body, do you think it could still have potential for a therapeutic effect?
Yeah, I think it would because, like, as Barrett pointed out earlier, if you move this way, you're moving your entire nervous system, not just the part. But I do want the patient's brain to come to that part of the body. I want to entice it to come in there. Say it's a wrist or whatever. I'm thinking of a wrist because I did treat a wrist CRPS post-fracture situation, not that recently, but a while back. And so, you know, she was like ignoring that side and doing all that stuff. I want her brain to know it's safe to go and hang in there and feel what's going on. But I certainly am going, I'm just touching. That's all I'm doing, touching and holding and waiting and feeling and not being provocative in any way, trying to be quite reassuring. Maybe doing tiny little bends of the skin, but just nothing provocative. Just trying to get the attention of the critter brain without freaking it out, you know?
Thank you.
So right up here in the second row.
Two questions, my two favorite questions.
Oh,
My two favorite questions. The percentage of nerves that end in the skin, of all sensory nerves.
sorry, say that again.
What percentage of
What
all
percentage?
sensory nerves end in the skin?
Well, there's sensory nerves everywhere to every part of the inside of the body and outside of the body, but when talking about cutaneous nerves, all of them are in the skin.
They all eventually
All
end
of
in the
them.
skin.
Well, some nerves that go into muscle don't have any branches that go to skin, okay? So there's certain nerves, you know, the names of nerves. Like a lot of the nerves in the brachial plexus only go into muscles that control the shoulder girdle, and they're buried deep in the body, and you can't directly get on them through skin.
Mm-hmm.
But you know what? You can move the shoulder blade, and you'll be moving all those nerves anyhow.
Uh-huh.
You'll be mobilizing them that way.
So we don't know exactly, no one's taken a good stab at the percentage of sensory nerves that actually finish in the
100% of the
subcutaneous.
cutaneous nerves with sensory fibers that are extraceptive go to the skin somewhere. 100%.
Okay. And then the percentage of sensory nerves that inform the somatosensory cortex.
All of them.
What percentage is, maybe I should ask that the other way, what percentage of the somatosensory cortex is informed by this,
Oh, I think about 3/4 of it. Okay, so there's at least 4. The sensory cortex is kind of shaped like, well, okay, there's that gyrus or whatever it's called. The dip in the brain between the motor cortex and the sensory cortex, right? Okay, so at the bottom of the sensory cortex, there's a Brodmann area. It's just this arbitrary division that it is responsive to proprioceptive input from muscular sensation. Okay, muscular sensation, but that's not cutaneous. So that part is dealt with by that area. I think it's called BA3 or something. And then there are 3 more areas climbing up the side of the sensory cortex and up into the kind of on top, on the surface. And those 3 areas deal with cutaneous input.
So about 3/4, 75%.
Yeah, directly. And then, but isn't like the stuff that's being, you know, the processing of the proprioceptive input from muscle spindles and all that stuff at the bottom isn't also feeding into the cutaneous parts? It is, according to...
So it really throws a wrench in all the previous reviews of mechanical manipulation and the results that we get from mechanical manipulation, because we're not keeping in mind that we're moving skin in space.
No, everybody ignores skin. This has been a beef of mine for a very long time. There's so much innervation there, and the somatosensory cortex is hugely reflective of skin. I mean, that's the outside of the brain.
I think we have time for just 1 or 2 more questions. Any last? We have a gentleman back here who has not asked a question yet this weekend. In the blue shirt.
Hi there. I was just wondering, is there a concern with your treatment if there's an attempt to avoid any pain, that we may be reinforcing the belief that pain is a dangerous thing that we need to avoid?
No, it's not. I wouldn't concur with that at all. What we're trying to do is not be a threat. And what we're trying to do is not be a threat to the critter brain. And it's not reinforcing, like, what I find absurd is the idea that we have to inflict pain in order to help pain. As manual therapists, I really don't agree with that. Never have. I can't imagine where that came from. Probably the culture. Anyway.
I guess I mean I don't know about other people. I mean I'm trying not to inflict pain, but through treatment and through movement, that may occur. I don't know if I can avoid it.
If the patient is creating their own pain, that's one thing. If you're inflicting it on somebody, that's another thing entirely, right?
I guess I just don't know. I'd like to know when, but I don't know exactly when it might happen.
Yeah.
I'm trying not to, but it can happen.
It's kind of like the shoreline and the sea. It kind of keeps moving, and you're not quite, like, try to keep your toes as dry as you can.
Yeah.
Just with your question, the sense I get is that you're is that it feels like you're asking, like, do we run the risk of treating the client as if they're fragile and therefore giving them the impression that they're fragile? Is that kind of in line with what you're
Yeah, I mean, if you're trying to keep your toes as dry as you can, that to me sounds like we're very much trying to avoid it, and that again is it's close to being afraid of the water.
All my comments are directed specifically and are couched in manual therapy. Okay, so it's manual therapy that I want to be clear about, that is what we shouldn't be nociceptive with. Okay, other stuff, yeah, you have to do your dishes or you have to lift them up in the cupboard and that might hurt a little bit or what. Movement might hurt, and you have to, like, teach your patients not to be afraid of moving and and that's not hurt doesn't equal harm and all that stuff. But when you are another nervous system outside of that nervous system and you are reinforcing the idea that it's okay for someone outside of that nervous system to hurt it, that's not good, I don't think. Now, you want the patient to have locus of control. I want my patients to have locus of control over me. I want them to decide where that boundary is. I don't want to assume that I know where that boundary is. Am I answering your question?
Yeah, I think so. Yeah.
Okay. I'm sorry, I honestly don't really understand the question.
All right, I think that brings
that
us
us?
to the
You're
end
done?
of this particular day.
Thank you very much.
I think there were some questions that didn't get asked yet, so that I hope that they will either track you down over
Okay.
dinner
All right.
or